Good evening. It is Thursday night, so it is time for FUB Club. If you were tuned in on Instagram a few seconds ago, my goodness, you had a bit of a treat in front of you. I wonder if you can put filters on, said Mrs. UB. Oh, look, you can do filters while you're live, said Mrs. UB. I broadcast to the world with bunny ears on. Hey, but that's good. And it was live. So, hi everyone. Hello, wavy people. Lovely to see you. Do post your questions live. I've had a few of you email in, which is awesome. So I've got a few bits and pieces to go through. I'll try and cover everything. Email ahead. How's everyone doing? I think, are we a bit optimistic? We're sort of coming out of this.
Yeah, I can feel the end, and there was a new statement tonight about 6 people.
Yeah, okay.
To meet from Monday.
Oh, 6 people, right. We have kind of set a provisional date as to when we're planning to open back in the clinic, but I'm not going to announce it now because we want to ratify everything and check everything's in place for that. But we've had our handyman making a few changes at the clinic and all sorts of things. So it's good. We've got through this, and let me know how you're getting on. Lovely to hear from you. Right, shall I go to some questions? Shall I do it?
Yes. Is anyone responding? Is anyone saying hello?
Yeah, people are joining in and they're saying hi and they're waving at me. Right, I have this question, and I've had this one a couple of times actually. So if you're on Facebook, this is going live on my Facebook as well as the Instagram. If you're on my Facebook, you'll see the questions flash up. For you lovely Instagram people, I will just read them to you. So when can you do, now this is how I love this, when can you do a breast uplift with just the donut or crescent shaped scarring? Okay, plus a typo, a special added typo. When can you do a breast uplift with just the donut or crescent shaped scarring? All right, what I tell everyone is essentially a breast uplift can be done using one of 3 main scar patterns. And they go from least extensive scarring, least effective an uplift, to most extensive scarring, most versatile, and most extensive uplift. The least extensive scarring is one with a scar just around the areola itself. The next is the so-called, and that one just around the areola is called a periareolar mastopexy because the scar runs around the areola, a periareolar mastopexy. The next is where there's a scar around the areola and then running vertically downwards, which is called a circumvertical mastopexy for some reason. Also logically called a lollipop lift because it does look just like a lollipop. And the main one with the scar around the areola downwards and in the crease, in the breast crease itself, is called a wise pattern mastopexy, or an anchor scar mastopexy, a keyhole mastopexy, inverted T. These are all names for that same scar pattern. Now, for years, and the last one, the wise pattern, is by far and away the most popular, most common. It's almost, if you're having a mastopexy, that's what you're going to end up with. But it doesn't have to be this way, and they all have their place. For years, the wise pattern, I'd say, was all I did. A vertical scar, there are enthusiasts out there who do almost all mastopexies and breast reductions just with a vertical scar. For me, I have to select the patients who use it because in my hands it has a tendency to lengthen the lower part of the breast, so I reserve it for those people who have a short lower pole of the breast. But that's not always the case, and then you'll find people who only do lollipop scar mastopexies. Whether in someone's hands it would have needed a wise pattern or in someone's hands they could have got away with a periareola. I find I'm able to do everything I want now with just the wise pattern and the periareola. I mean, almost everything. I didn't used to touch periareolar mastopexies. They are legendarily hazardous. If you had a map of plastic surgery, it would say on it, "Here be dragons." It is the way potentially to badness, and you've got to be careful. There are a few precautions you must take, and I would say make sure your surgeon does them a lot and isn't doing yours for the first time because they look deceptively easy and they're not. Now, a periareolar mastopexy involves the areola has a donut of skin removed from it. There is some undermining done, and then that skin is cinched in, and that would create tightness of skin. But if the donut is not concentric but is eccentric, is slightly above it, so the areola is at the bottom and the donut of skin that's removed is designed so that it's higher, then when one of those circumferences is brought into the other, then you get a lift with it. You can't get much of a lift. You can only get maximally about a 3 centimeter lift. So if someone's got more nipple droop than 3 centimeters, then it won't work. But if they have got only 3 centimeters of lift, then it's a wonderful procedure. So why do I say it's a dangerous thing? Well, what can go wrong? Hey, what can go wrong is the scars can stretch out again. So in the healing process, there is force being exerted on the skin and the scars from inside outwards, especially if you've got implants in at the same time. And so what's it going to do? Well, the skin wants to stretch, the scar wants to stretch, everything does. But the scar is more likely to stretch. It has greater compliance than the skin. So it would stretch preferentially. So you would end up with the nipple back where it started and a big, wide, ugly scar. And this is what you hear about. If you do your research and read into this, you will see disasters with periareolar mastopexy. And I found only one way of making it work. And this was told to me by Dennis Hammond, who's an American surgeon, who I had to visit in order to get this tip. And he says, use this one stitch, use this one. If you use any other, it will go wrong. If you use this one, it will be fine. And he was right, it's true. And the stitch is a non-dissolving stitch. And it's one which is soft enough to be able to tie knots nicely and sit under the skin and live there forever. And when you tie that new circumference of stitch and you knot it there, you've locked that. Now the scar cannot stretch. And I actually have, because this question came a while ago, I have a video. So we have, I'm going to rewind back and do that again. Can you still see it?
That's it, yeah.
Yeah, okay, cool. So this is a periareolar mastopexy going on. And tell you what, I am going to show you on Instagram too. Here we go. You get to see my screen. It's a scary moment. You get to see what I'm looking at. So, this is a periareolar mastopexy, and if we start at the start, you can see that that donut of skin that's being removed is biased towards the top of the breast compared to the bottom. Now, that nipple is too low on that breast. That would not be a pretty breast. I've just put an implant in it, but if I left it at that with that nipple pointing downwards, it would not be an attractive breast. Now, I've put in that dissolving stitch, and it takes ages to put in, but, well, it takes a while anyway, not ages. But once you do and you've got it right, this is the nicest moment in surgery that I know of. You tighten this knot, and look at that magic. Look at that. That's just beautiful, isn't it? And there we have the nipple relocated in the right position. You can see some pleats around the scar, and those pleats have to happen because essentially we've taken a large circumference and cinched it into a small circumference. But if you don't push the technique, so I'm going to hide that. If you don't push the technique too far and you're only going for your 3 centimeter lift, then that will be enough. That cinching, that pleating will settle down and it vanishes completely. It's telling me our broadcast. Oh, that must be the old one. So there you go. So that's it. That's when I do it. So I do it when it's not pushing it too much, when the patient's appropriate for it. You can slightly push it more than that 3 centimeters by doing tricks if you're using implants, by using the implant to give you an extra 0.5 centimeter or 1 centimeter. But essentially, I don't like to push it too far. Okay, next one. Did that make sense? I hope it made sense. I'm gonna rewatch this and think, oh my god. Okay, next question. It's short to the point. My implant has rotated. What can I do? Okay. Breast implant rotation is a risk of any kind of implant, but when they are round implants, it doesn't matter. Breast implants that are round that rotate are the same in every direction, so big deal. If you've got a teardrop implant and that rotates, that is bad news. That can have you with an upside down looking breast. So if that happens, what you can do, well, I mean, it's too late for this, but the best thing you can do is avoid it. And a lot of the avoidance is the surgical pocket, is the way it's dissected. You want the implant to sit in the pocket hand in glove. Sometimes that's less easy than it sounds. If someone has had massive weight loss and they've got less good tissue support, then that pocket can enlarge even after surgery. During that post-surgery period, you want to be supporting that implant in a supportive garment, and I recommend that those are worn full-time for 6 weeks at first. And by that time, you should have a capsule that's supporting it. But what if then that does happen? You do get a rotated implant. It can be rotated, by the way, axially, or it can be flipped too. So it can be flipped so that its superficial surface lies deep and its deep surface lies superficially, and that can affect round implants too. In either case, you can maybe manipulate it back with just with your hands. Some patients tell me about doing that in the bath, and they're able to turn it and do stuff like that. But if it's happened once, more likely than not, it's going to happen again, I'm afraid. And a long-term solution is much more often than not a return to theatre. So returning to theatre, the implant gets temporarily removed. You can reinsert an implant that you've removed temporarily as long as you look after it while it's out. The pocket gets reduced, the pocket gets stitched internally to make it smaller so that the implant does fit it like a glove, and then returned, and then you have to do the same precautions again. One of the biggest risks of that is that of it recurring, of the implant forcing those stitches open in the early healing period. Another risk is that you can get little skin dimples, internal dimpling, externally visible dimpling actually, where that pocket has been reduced, but that is not so much of a worry. That does get better by itself. So I do warn people, if I'm ever doing that kind of secondary surgery, that I really will be quite aggressive with getting that pocket the right size and really reducing it, and they may see some external dimpling, but it does get better. So yeah, those are kind of your options for implant rotation, I'm afraid. Okay. Oh, this is interesting. So we've had someone ask here, what is the revision policy for capsular contracture? And we get a few of these questions actually about revision policies. And one of the things I've done during lockdown is put together a video that really conveys actually what is included and what's not. Patients are often frightened that a lot is not included, and actually I think they're surprised that more is included than they thought. So when it comes to what's included, once you've paid a consultation fee, all your consultations thereafter are included. If there are extra nights stay for unexpected reasons, or unexpected additional surgery during your admission, or unexpected wound care or things like that while you're recovering, all of that stuff is included. You may need to get prescriptions because there'll be private prescriptions which you go to a pharmacy for, so you may well be paying for those if you were to need additional prescriptions. When it comes to surgery, it always depends on whether the outcome has met expectations or not. If the outcome hasn't met expectations, then most of us, it would be my policy, would want to put things right. And so that would come under our revision. Now, when it comes to capsular contracture, that is an outcome which is actually one of those things that can just happen. So capsular contracture is not routinely included in a revision policy. They say if you leave a breast implant in for long enough, you will develop capsular contracture. It may be 10 years, it may be 30, but eventually it will. And so capsular contracture, the risk of it happening, and certainly the risk of needing further surgery, is something that you have to accept if you're going to proceed with breast implants. And that's generally on you. However, I have had one patient now who developed capsular contracture early, fast, within a year. It was actually within a few months that it started to happen. And we put her on a medication that has been shown possibly to reduce the risk of capsular contracture progressing. It helped with pain. It didn't really change appearance much because capsular contracture can be painful. And so in those circumstances, and she did understand that capsular contracture can happen, so we sort of didn't feel obliged to do a revision, but did anyway. It was something that we thought, okay, look, this is not what you're really expecting to get yourself into. Capsular contracture can happen, but really, within a year, that's bad luck. You're not really enjoying your breast augmentation. So I spoke to the hospital, I waived my fee, the anaesthetist kindly waived his fee, and the hospital waived its fee. So revision surgery in that case was free of charge. But it always depends on what you've established with your surgeon in advance as to what the parameters will be. And we've now changed our system a bit so that as well as sending people consent, we also send a list that says, in the event of dum 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 dum, this is covered, and in the event of la 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 la, that is not. So trying to make it as clear as we can. Okay. Here's an unusual one. I don't hear this much. Do I need to stop my Roaccutane before surgery? Okay. Roaccutane is a drug in the group of drugs called retinoids, and it's used to treat acne. So people may be on it at the same kind of age, those sort of late teens, early 20s into their sort of late 20s, that they're also looking for this kind of surgery. So that question actually does come up not that infrequently. The problem with Roaccutane is that it may impair wound healing, it may impair skin healing. So surgery is said, to be contraindicated, and also a whole load of non-surgical treatments, anything that might resurface your skin, laser treatments, plasma treatments, chemical peels. We are very cautious with people who are on Roaccutane and would generally ask them to stop. That said, when you get down to the nitty-gritty of it, the evidence for that is not so great. So there haven't been that many studies on it, but the ones that are out there with smallish numbers, sort of 40, 50, 60 patients, that kind of thing, seem to show no real difference in wound healing under most circumstances for minor surgery. And most plastic surgery is relatively superficial surgery. Non-reconstructive, of course. The reconstructive stuff, if you saw my last week's webinar, can be seriously invasive. My friend Theo telling me he was holding someone's lung the earlier week. But anyway, cosmetic stuff, we're not normally holding your lung at any point. And with that level of relatively superficial surgery, actually the evidence isn't there that it does any harm. Now, so we could probably get away with it. But a prudent approach, given that there is this concern and that usually we can stop it with no great detriment, that is the normal recommendation. So unless there was a really good reason not to stop it, that's what we'd go with. If there was a really good reason not to stop it, we'd kind of think about deferring surgery for a while, because we often can plan and defer when the surgery happens. It doesn't usually have to be this month or this 6 months. So yeah, okay, that's Roaccutane. Okay. Now, I like this one. Now, this one came into, was this a private message or a messenger feed one? Are breast capsules more likely in very slim women?
This was a question that came up today.
Okay.
A new patient.
Okay, so first of all, what are breast capsules? If you've got a breast implant that's been put in, your body will eventually wall it off with scar tissue. That happens 100% of the time. It never doesn't happen. And that's called a capsule. The risk of that developing that I quote, that's 100%. It can, in some people, go on to form this thing called adverse capsular contracture, which is where the capsule starts to shrink and contract. And if you've got a floppy breast implant that then is being externally had pressure put on it, then it becomes more and more like a sphere. The surface area reduces, the volume stays the same. The thing with the smallest surface area to volume ratio is a sphere. So this breast implant starts to progressively resemble a sphere. So what does that mean in your body? It often sits higher, projects more, becomes harder, and may be painful. So that's adverse capsular contracture. Capsule happens in 100% of cases. ACC is variable depending on the type of implant. With the ones I use, I quote an incidence of 5% at 10 years. So it's usually an uncommon event, but one of the more common adverse outcomes of breast implant surgery, actually. So is it more likely in slim people? No, it's not more likely in slim people, but generally if you're very slim without much padding, you're more unforgiving in terms of irregularities. So if you were to develop rippling of your implant, folding of your implant, you're more likely to see it. If your implant on one side was to get more projecting and harder and sit higher, you're more likely to see it. Sometimes a capsule, if you imagine we've got this sort of reducing surface area, it can cause the implant within it to actually fold because it's got less surface area to sit in and actually fold and crease. And if that happens, again, if you're slim, you might see the fold, or more likely at the edge of it, you might see the knuckle that forms where you've got this soft implant that folds. You might just feel a lump or a knuckle. And we get lots of, well, not lots actually, but I've heard a few people coming in and saying, I think I've got this breast lump. What's that? And you say, actually, it's the implant. If you flatten it there, it goes and it appears there. and that can be a capsule phenomenon. So yeah, they're not more likely if you're slim, but you're more likely to be aware of it if you're slim, I'm afraid. Okay, we've had a instant message. Hello, bsleeve.vsg. There's got to be a backstory there, right? That's got to mean something. Okay, hello. Can you combine FDLTT, which means fleur-de-lis tummy tuck, stroke 360 lift? A 360 lift means a tummy tuck that goes completely around the body, also called a total body lift. Can you combine that with breast lift with implants, or just normal tummy tuck with breast lift? Okay, so combined surgeries. You can do it. You can do all of this stuff. The question then becomes, should you? And it gets difficult, and it gets difficult for a few reasons. First of all, surgically, it's bloomin' exhausting. So a fleur-de-lis tummy tuck is a long operation. It's a big operation. An extended fleur-de-lis tummy tuck is a big one, bigger. A 360 is a big one that involves you being anaesthetised face up with a reinforced tube, then being turned face down, then we do the back stuff first, then we get a team in, turn you the right way again, re-prep you. It's kind of like we're starting another operation. And by the end of it, honestly, you're done in. And to then go on and do your mastopexy and your augmentation, and to be a bit of a perfectionist about it, so that if something's not quite right towards the end, you're not going to say, you know what, we're done. You're going to say, we're not done. We're carrying on. That's a challenge. So if you're looking at what you've just said there, we were listing maybe 6 hours of surgery, and the surgeon is scrubbed, so you're not having a drink, you're not going for a pee, you're not stopping, and you're concentrating hard and manually working on it. So it's a lot of work. You can get assistance in, you can do combined surgery, and if you do that and you bring it down to a more manageable time, then it becomes more feasible, and team working is really good for that. So it can be done in that sense. And you know what? We do longer operations, and when I was a breast reconstructive surgeon, we were doing 6 hour, 8 hour operations. When I was doing head and neck reconstruction, we were doing 12, 14 hour operations. You know, we can do it. The other thing to think about is your recovery. And I mean, it's a bit ouchy doing all of that. And if you've got sore breasts, at least it's just your breast. But if you've got sore breasts and sore tummy and sore back, and there's just nowhere you can find a comfortable place. And day 1 of no sleep isn't so great, but day 6 is worse. And when you're really doing all of these things, you've got to think about how you're going to recover. Most people, when we stage our operations, are pleasantly surprised how comfortable they are, how painless they are. If you have a look on my YouTube channel, and you'll see someone talking about the aftermath of their tummy tuck surgery, and they're kind of saying, it's the morning after, I'd just finished it the afternoon before, and they're saying, yeah, it's no big thing, you know, this is fine. Hurts maybe 2 out of 10 when I move. But when you're doing lots of surgery, there's nothing to get away from the fact that every bit of your body hurts. And that then has knock-on effects. So you may think, I'm hard, I can take it. And you probably can, but we're probably going to give you an amount of painkiller that means you're not moving so much, which then means you might develop a cough, which then sets up its own problems with the tummy tuck you've just had. And you might get a bit of a chest infection. And you know, it can set this spiral of badness going. So yes, you can do it. I generally try to talk people out of it. I hope I've talked you out of it. I do tummy breast combined surgery, mummy makeovers, but I prefer not to do those in the really huge cases, the really big breast reduction or breast uplift, the really big tummies. And if they are big, if they are really their own operation in their own right, then give them the respect they deserve and the time they deserve. So that's my approach to that. I hope that helps. I hope that answers your question. It's usually not the answer you want to hear by virtue of the fact that you're asking. Okay, there's more. Would you advise having a breast lift and implants separately from a tummy tuck? And if so, how long can you wait? Okay, so hello, Leah Marie, thank you very much. OXO, is that sort of kiss, hug, kiss type thing? Yeah, so it's much the same question. It depends. So when it doesn't sound necessarily like the one that you're talking about is this huge fleur-de-lis extended tummy tuck. So under those circumstances, yeah, you can. I can put you in touch with patients of mine who have had it done. You'll see photos on my, mostly on my Instagram actually, on the before and afters where patients have had the combined surgery. It can be done. It is done. But I always have a thought to how big is this tummy tuck? How big is this breast reduction or breast uplift? How much liposuction am I doing? And how resilient is this person? How are they going to cope with it? And the other thing that comes into that, if I'm totally honest, how far away do you live? Because if I'm doing stuff that's going to give you a greater likelihood of needing to come and visit me more often, then it's no good you living in Sunderland and I'm based in Berkshire. Because if you're going to need, if you have, I don't know, a wound problem, an infection, something, and you need to visit me weekly, then that's going to get pretty old pretty fast. So you've sort of got, I do temper it. We have patients who just live around the corner, and you can kind of be slightly more racy because if it comes to it and they understand the risks, they get a bit of a wound problem, they can come in, they're being looked after by you, by the nurse, they can come in 3 times a week, it's not a big deal. But if that happens when you're a bit more distant, it's an issue. Okay. Oh, right. So, bsleeve.vsg. The name comes from the fact that I had gastric sleeve surgery. Okay. And after gastric sleeve surgery, you can dramatically shed weight, and you can find yourself needing the more extensive kind of stuff. The other thing is that when you've had this sort of massive weight loss type of outcome, it's really not, I find myself doing a lot of auto-augmentation type procedures in such patients. So rather than just a standard breast uplift, you will have so-called vegan boob job, where the droopy part of your breast is preserved and kept and converted to a sort of natural living breast implant that is then stitched, and it can be stitched unlike a breast implant. And used to augment your breast tissue. So that's a really lovely way of managing the breast in people after substantial weight loss. But it takes time, it's more complexity, and to get it as good as you really want it to be, you sort of want to do it justice. So yeah, I wouldn't do that at the same time as the other stuff. And when it comes to the other stuff, especially a 360 tummy tuck, well, when you've had massive weight loss, what often happens is the bum can deflate. It can lengthen and lose projection. And that is something that, people often dislike. And when you've had the rest of your body contouring surgery and look amazing, a flat bum is often the last thing that makes you think, you know what, I still feel like I look like a massive weight loss patient. And what you can do if you've preserved that tissue at the back of the tummy is actually use that like a buttock implant. I don't like using buttock implants. They do have a high complication profile. I am watching that sphere with great interest, and I'm keeping an eye on it, and I will change my view on that if the data changes. But at the moment, I don't do buttock implant surgery. I used to do fat graft surgery to the buttocks. We can't do that anymore because of the high risk of death with that. So there's few options for improving buttock contour, especially in these people who could really benefit from it. But that is an option, and it's a good one. So it's always sad when they've had the 360 tummy tuck and no one really thought, hang on, could we be using that tissue? Shall we preserve it? Shall we do a buttock lift at the same time as that and use it to really create projection? All right, Heather, when are you likely to start doing tummy tucks? Sorry if you already said that, I only just joined. It's okay, I haven't already just said that. Would I do a standard tummy tuck and breast lift at the same time? Yeah, I do. So I do standard tummy tucks and breast lifts at the same time, but not huge ones. So it kind of depends on you. Book in, let's have a consultation and we'll see. Now, but when are we going to get going? When are you likely to start doing tummy tucks? Okay. So this whole getting going question, and I mentioned a little bit about that at the start. It looks like we might be getting started again. For clinic attendance, so coming to clinic, maybe having some non-surgical treatments, we're thinking mid-June. For Certain non-surgical treatments, that will be pushed further down the road. So things like lip filler, we don't want to be mucking around with your mouth too much. We don't want you opening your mouth. We want you to be wearing a mask, a face mask, as much as possible. So that will be pushed further down. Minor surgery will probably be doing in the clinic local anaesthetic stuff, especially if it doesn't involve the face, around the same kind of time. Then we get on to surgery in an operating theatre. Body surgery, breast surgery, not facelifts, not rhinoplasty. I don't do rhinoplasty anyway, but sort of body stuff. We believe we can get going again in July. That's when we think things are going to happen, with some limitations. So there are some things that are considered higher risk, and one is aerosolizing procedures, things that might create a mist of horrible coronavirus, which everyone would then inhale and get and become very ill. So power-assisted liposuction may be in that group. Power-assisted vibrating liposuction. And so if that's the case, then things that do also involve power-assisted liposuction would also be pushed a bit further down the line. Such things include fat grafting, lipofilling, abdominoplasty often. So those won't be probably amongst the earliest things we do. A breast augmentation on its own, no aerosolization of anything, that can start pretty soon, presumably. A tummy tuck with no liposuction could start pretty soon, but most of my tummy tucks statistically do involve liposuction. So it depends on the kind of surgery. I hope that's answered your question. Would you do a tummy tuck under local anaesthetic? You are not the first person to have asked me this. If you had been the first person to have asked me this, I'd have been a bit of a loss, because it's not an easy question. I have never done a tummy tuck under local anaesthetic. A mini abdominoplasty, sure, would be reasonably straightforward. That's not really an abdominal, I mean, it is, but it's much less dissection, much less undermining, so yeah, that can be. A tummy tuck, though, you could do more, but we had a patient, and it was interesting. She was telling us she didn't want, we were saying, well, why? She's fit, she's healthy, she was fine for it. Are you scared of anaesthetic? No, I'm not scared of it, she said. But after a previous anaesthetic, I got really depressed. And we hear sometimes about sort of low mood following general anaesthesia. And talk to the anaesthetist, and it's something they haven't really much heard of. It's not in their literature, it doesn't get reported back to them. But it's a thing that as the surgeon and the nursing staff hear not infrequently. And I thought, okay, bit of low mood, but, can you push through? I then met this lady again, and her husband said to me, you know what, no, she's trying to be brave here. A bit of a low mood. I mean, this was awful. It was debilitating. It lasted 6 months. It was her, it was the family, it affected everyone. So she really, really wanted a tummy tuck and really, really did not want to be put to sleep. So we investigated, spoke to the anaesthetic team, who are a fantastic team and actually will try to make it work. As long as someone's fit and healthy and it's safe, they'll try to make it work. And I said, yeah, okay, we can do it. We can do high spinal, epidural. We can do, there are ways of anaesthetizing most of the abdominal wall. Then you can do things like rectus sheath blocks. So we can put local anaesthetic into some of the deeper areas that might still be uncomfortable. But there would have to be an agreement that if it was too uncomfortable, that you would agree to being put to sleep during the surgery. Would say, okay, you can't proceed with all these things we're doing, tumescent anesthesia, and where you infiltrate a lot of fluid with anesthetic in it. All of these things, if you're getting to a point where you just can't do it, then you'd be put to sleep. So it's not routine. It can technically be done, I'm assured. I haven't done it. It's unusual, and you'd need to have a good reason for that. So a good non-health reason, because if you're that unfit for the surgery, then I would probably decline you either way. Well, I would decline you because you've got to be in a state where you could convert to a general anaesthetic. So if it was due to ill health, I'd say no. If it was due to needing reassurance about anaesthesia, then I'd say, let's get you the reassurance. We can get you to speak to the anaesthetist. We can, make you happy with it. There'd have to be a really good reason. And I think that lady that I mentioned did have a good non-physical health related reason, but most people don't. So I would do it. The reason the normal way is the normal way is because it's really, I've got to say, the better way. And I wouldn't want to compromise the surgery for the sake of the anaesthesia that you have. I wouldn't want to do less do a less good job, try and rush it, anything like that. Okay. I like this one. Yeah. So, I'll come back to that one. I'm going to break it up a bit. So, someone's messaged in and said, should I have thigh liposuction or a thigh lift? So, do I need liposuction or a thigh lift? I'm in my 20s. My thighs are disproportionately large. On the inner thighs, there's some wrinkling that almost gives the appearance of sagging. Do I need a thigh lift or can I get away with liposuction? There's a short answer to this and there's a long answer to this. The short answer from what you've just said, you almost certainly need a thigh lift. And it's not what you want to hear. And in your 20s, you don't want the scars. No one really wants the scars from a thigh lift. But if loose skin and sagging and skin texture and contour are your concern, then liposuction is not going to make it better. In fact, it will make it worse. It will do that. And even with people without major skin concerns, they'll say, my inner thighs are just a little bit full. Can you do some liposuction there? I like my legs, I'm pretty happy. I don't want a thigh lift, I don't need a thigh lift, but I would just like my inner thighs to go straight up a bit more, or maybe go in a bit at the top, not sort of meet in this kind of way in the middle, not join in the middle. And liposuction is a surprisingly unhelpful way of addressing that, because you can empty out the inner thighs, you can, but the shape of the thighs as they meet in the middle.
Do you want to draw?
Do I want to draw? I might be showing everyone my shorts if I draw.
That's okay.
Okay, you can see my shorts.
People won't mind.
Okay.
It's summer.
So thighs. There's a groin, there's an inner thigh. There's also a thigh. There's some knees. Sort of looks a bit like me, right? Right now.
Turn around when you.
So, thighs. Because of the shape of the thighs here, because of the way they come in, you can empty that fat. Sure, you can do it. That's absolutely fine. But when you do, that deflated skin just wants to hang in that direction. So as you look in the mirror, there's been no real change in the contour. You can pinch it and it feels thinner, but since passers-by don't go around pinching the inside of your thighs, unless you're in a cafe in Rome, then that doesn't really help. That hasn't really addressed the situation. So under those circumstances, actually, with the people who could get away with liposuction, I recommend cool sculpting. I think cool sculpting is the way to go. I see none of that kind of skin laxity, excess skin that you can get with liposuction. And if there really is excess skin to start, I really recommend a thigh lift. And the way that I bring patients along with me on that journey is to actually show to them how much extra skin they've got. And there's a way of doing this. It's a really neat trick. So first thing I do is I draw on the patient, I draw where I want their scar to end up. So there's a line on the inside of your thighs where the scar will be least conspicuous from the front and from the back, and that's where I want the scar to be. Then what I do is I hover my pen right there and I pull the skin backwards and I mark. Once I've got the skin as tight as I want it to be, I mark where my pen is. I haven't moved my pen, but the skin's moved underneath it. Then I swap hands and I pull the skin from backwards to forwards and I do the same again. And having done those two maneuvers, I then do the same thing up and down the thigh. And when I've done that, you can see the width of skin that can be removed, and then I measure it. And when patients see that they don't have just a bit of excess skin, they've got 10, 15, 18 centimeters of width, we're not talking length, of width of skin to remove before they get the contour that they want, then that brings people along with the concept that, a bit of liposuction is not going to sort this out. Nothing, removal of that skin is where they are needing to go to get the result they want. And the scars are interesting. I mean, scars, there's this old adage, scars heal from edge to edge, not end to end. So they will heal just as well if they're long or short or whatever. And if you get a good scar, so if you do everything you can to look after your scar, and your surgeon has a good track record for giving good scars, then it kind of doesn't matter. Place them in a place they're hidden, look after them, take care of them, don't let them in the sun at first, and they should do okay. So that's my thoughts on that. Charlene, thank you so much. I have a huge fear of anaesthetic. I have had 2 C-sections and now really happy there may be a chance to have my tummy sorted without going under. Yeah, it's possible. It's done, and some people make their name from it. So if you sort of, that's a kind of niche thing maybe, that there are a few people say, yeah, I do my wide awake tummy tucks. I don't think many of us do them, to be honest, but yeah, it's not impossible. Okay. Oh yeah, I've had spinal blocks for my C-sections. Right, it doesn't cover everything we need, and the problem with that is most of the surgical pain happens from skin, and actually once you get through skin and then you go a bit deeper, then it's actually relatively painless until you get to the next layer that feels anything. And then in the tummy, the next layer that feels anything is called epimysium or muscle fascia. And muscle fascia, yeah, you'll feel that, and it's very hard to anaesthetize muscle fascia. So that's when I was talking about this rectus sheath block. How long can you expect to be in surgery for a full tummy tuck? As little as maybe an hour and a half, 2 hours, and as long as maybe 6 hours. It's hugely variable because people come in with different tummies and they all get called a tummy tuck. I've actually internally in our systems, got to say, I've started to code them differently, because it makes no sense whatsoever to talk about this huge range of patients as if they're the same thing, as if they're all X amount of minutes, 2.5 hours, cost, requirements afterwards, recovery time. They're not. We all call it a tummy tuck, and even the different kinds of tummy tuck, but within that there are very different kinds of way that people behave. So the simplest way I have of classifying them is actually by starting weight, because if you have a BMI of more than 35, you're a totally different kettle of fish to someone who has a BMI of 20 having a tummy tuck. And there are lots of categories in between, and so yeah, it's hugely variable. I'd say about 3 hours is probably standard. Quicker if someone's got an operating assistant. And there's some variability. Okay, gosh, so there's a flurry of questions. I'm booked with you on the 10th. How long is it likely to go ahead? Hey. On the 10th of I should know this, June or July, but I don't have my
July.
10th of July. Thanks. Yeah, 10th of July. I'm not going to say what operation you're having. But 10th of July, but with the provisos. I don't know if you were listening earlier. So there are some procedures that there's a really good chance of that going ahead, and there are others that aren't. The things that we're being asked to think about is, can we reduce the complexity of surgery with each case? Can we reduce the length of time it will take so people are likely to recover less time? I don't think that's actually less relevant to the stuff I do, because there's no kind of distinct, whether I do this procedure with or without liposuction, or with or without an auto augmentation, you're still going to go home after 1 night, not 2, not 0, whatever it may be. So I don't think those things are that relevant. I don't think people are actually going to contract coronavirus on the operating table. But there's a whole load of coronavirus bits of the consent that we are adding in and that need to be discussed in advance of surgery. But yeah, 10th of July, we're hopeful. At the moment, we believe we're going ahead. Okay. Okay, I was going to come to this one. So thank you so much for your question about hairdressing and breast implants. It's actually on my list over here. Tell you what, I'm going to prove it. So I'm going to put it up there on the Facebook screen. So
I got it on the list. I promised I'd put it there.
So it's on the Facebook screen right now. As a hairdresser, should I get breast implants above, under, or over the muscle? And how soon can I return to hairdressing after breast implants? Okay, so slightly different questions. I don't know if they were both from you. I think they were.
Yes.
They were. Okay, so I'll start with the other one actually. As a hairdresser, should I get breast implants under or over the muscle? You being a hairdresser is not going to affect that decision, I would say. Now, I know what hairdressers have to do because my mum was one. I have great affection for the hairdressing community. And I know how hard you work as well. And you stand on your feet and your arms and your shoulders and you're always doing this. It's short and it's across the chest. That said, the thing that influences plane of breast augmentation is how much thickness you've got between the outside world and your chest. If we can put an implant above the muscle because there's enough thickness to hide it, great. If we need more thickness, then we get that with the muscle by going under the muscle. It doesn't really affect your recovery in terms of returning to work, even doing what you do. I had a lady who was a professional bodybuilder have breast surgery with me, and she was lean as anything, lean, not an ounce of fat on her and not much breast tissue either. And I said, look, ideally I'd like to go under the muscle here, but how is this going to impact your bodybuilding? And I was saying, I worry that it's going to affect how much you're going to be able to push. And she said, well, okay, she thought about it and said, in bodybuilding, it's about how you look, not about physically what you're able to push. So, I'll go with it. And if I'm able to bench press less than I used to, fine. So we did it. She noticed no difference. She was quite a high level athlete. She's actually gone on to have great success, as it happens. High level athlete. And she said to me, not only have I not noticed any difference, but I'm still literally able to bench press the same weight. So even at a high level of sporting achievement, in which people are quantifying their recovery, having implants under the muscles doesn't seem to affect it in the medium term. Short term, sure, you're recovering. The recovery is probably a little bit longer if you're under the muscle. But longer term, it doesn't matter. So you could do either. The other part of your question in the other medium was, how soon could you return to hairdressing after breast implants? Okay. That probably will alter slightly. I'd maybe say it's a week difference between above and beyond muscle. There is no evidence to support that. It's just I'm trying to apply principles and common sense. I normally say after breast surgery of most kinds really, breast augmentation, breast reduction, breast uplift and combinations of them, that most women, I used to say take 2 weeks off work. Almost all of them came back and said for the second week I felt like a total fraud. So I now say take 1 week off work. If someone's in a job where their boss, those bosses, right, where then they're going to be a bit difficult. If you've got a kind of difficult boss, then just say 2 weeks. And if you're back early, they'll be delighted. And if it's 2 weeks instead, then that's what they were planning anyway, so it's fine. Better that way round. But realistically, office kind of work, you can drive after a week, usually. Most people feel ready to drive, and I go through how you can know whether you feel ready to drive. Most people feel ready to drive after a week, and that means you can get back to office work. Now, hairdressing's a bit different. Hairdressing's not office work. And what I would say is maybe an extra week, so maybe it's 2 to 3 weeks rather than 1 to 2. And maybe you want to think about, don't do those big long days. Maybe can you divide your days so that you do mornings or afternoons? I mean, people need to get back to work usually. Although it seems that we will taken 68 days off in my case. But people need to get back to work usually, and people, especially self-employed hairdressers are quite keen to get back to work. So I don't want to prolong it any more than it has to be. Usually a couple of weeks. Will you do your implants any harm? No. If you're supporting, you'll be taped at first. You'll be wearing a supportive surgical bra. The right garment is important. Don't get a sports bra. Get a surgical bra, and we're not affiliated to any in particular, but we've got some that we really keep coming back to time and again because they're really good. If you do that, then you should be able to get going. And most people find their discomfort minimal after even a week. Most of my patients after breast surgery stop taking most painkillers after 5 or 6 days. A few take them a bit longer. We surveyed our patients recently, actually, and we should publish that. We must publish that. Yeah. Anyway, I digress. Okay. Yay. Sorry. Thanks. Yeah. Cool. Good. Okay. I think. What time is it? It's 10 to 8. This is end of webinar time. It is time for our. We like to wind up around now because we like to get you to clap for the NHS if you're doing that kind of thing, if you're still doing that. There's been a bit of controversy about that, hasn't it? Some people are saying stuff the clap, and
I think lots of people today are saying today's the last day.
Is it the last day? Oh, come
Some
on, let's do
people
it,
are
shall we?
saying, I don't know.
Let's do it.
I think it's good to show our appreciation.
I think it's nice. I think there's all sorts of social reasons. We're getting to see our neighbours.
I'd love them to be paid more, but that's not in my hands.
Yeah, you know what? This is a real bugbear of mine.
Sorry.
Honestly, NHS workers just need to be paid more. And I can get really political now. They just need to be paid more. They're not paid what they deserve by a long stretch, and they should be paid more. That's what I think. But let's show our appreciation in the way that we can. And on that note, tonight's Thursday, so tomorrow is Friday, which means it's Hydrofacial Friday. Every Friday during the lockdown, we have said we are giving away a hydrofacial for free to an NHS worker that you nominate. In fact, last week's NHS worker nominated herself, which I loved. So reply to our post, give us your nominations. You've still got a bit of time to get it in for this week. We've had some really good nominations already, actually. So it's going to be very tough. Yeah, I know. So it's going to be really tough. We've had some great nominations. This may not be going on for that much longer. I mean, who knows? We don't know. So get your nominations in. And thank you. What's your availability in August like? Please contact Rebecca. She will handle all of that. info@eterno360.com or 01753 840 411.
Yep.
Or
07519 527 268.
or here, or message us, or whatever it may be. And yeah, we will get round to you. Rebecca has kept a super organised spreadsheet of everyone who's waiting for various things.
I hate spreadsheets.
She hates spreadsheets, but she's embracing them. All right. Good night, everyone. Have a great Thursday. It's great to be there. Thank you so much for all your questions, and lovely to see you. Take care. Bye now.